morning. I'd like to call this meeting to order of the Minnesota Senate Health and Human Services Finance and Policy Committee. It is Thursday, April 9th, 2026. And we have an agenda today with several bills. And then first, we'd like to have an informational discussion about governor's budget language. Members, as you recall, we had presentations by the agencies. That was prior to break. And they went over their budget proposals. And now today what we're doing, because the language wasn't available for the bills until this week, we are getting those bills introduced. And they weren't introduced in time for, an actual regular hearing today. So that's why it says informational, but they will be out, I believe, later today. They will all be introduced as bills later today, and you'll be able to see them online as introduced bills. So what I'd like to do today, we need to be able to have the language before us, and then next week when we are working on putting together our budget omnibus, that language will be available if we choose to include provisions from the governor's budget in that bill. So what I will do is just bring your attention to each of these that are in your packet. And then if you have a specific question about that agency's proposal or bill, we can take questions. There are representatives from the agencies here. So first, we've got the Department of Children, Youth, and Families. That is in your packets. It's revisor number 26-07869. There was an amendment posted for that bill as well, which I believe has been handed out, I believe. So you have that. And members, do you have any questions about the DCYF language? Okay, I don't see any questions about that. Then we have the Department of Human Services, which is 26-8139, and that there is an author's amendment that they created. I don't think that is just it. Okay, that was just handed out. Okay, that was handed out as well, but that just was released, so I realize people haven't had time to review that, but it is posted. Are there questions about the DHS language? Senator Abler.
Thank you, Madam Chair. And so just, so this is the entire DHS budget, so it includes items from the other committee as well as this committee. Is that right? This says aging and... Was it just
things, Senator Abler, the bill represents things within our jurisdiction. There's some difference between the House and Senate, so I'm not sure that we can say that how they. Okay, so it's only our jurisdiction. Okay. There are a few items where there's differences between the House and Senate, what we include, so. All right,
well, I'm sorry, I had to ask questions I don't know the answer to, but I didn't know the answer to that, so that's helpful. Because could somebody point out to me where the OIG sections are in this bill? I presume that's in here, right?
Yeah, if a representative from DHS could come forward. Welcome, Ms. Didion, and if you could state your name for the record, and then did you hear Senator Abler's question?
Thank you, Madam Chair. Yeah, Senator Abler, let me just pull up the document really quick here. And are you asking about the program integrity language or everything relevant to the Office of Inspector General?
Senator Abler.
All of the above, please, and then I can just at least know where to read, because you know I'm kind of interested in that topic, so thank you.
Ms. Didion?
Yeah, Madam Chair, Senator Abler, it's in, I believe, Articles 4, 5, and 6. The Office of Inspector General article, the Background Studies article, and the Uniform Services Standards article came from the Office of Inspector General.
Well, thank you. And
Senator Abler?
well, I'll take a chance to read it offline. So that's all I'm intending to ask. Maybe I'll offer my comment as well. Then that'll be the end of this whole cluster for me. In the human services component, there's a lot of fraud work, most notable, and a lot of horrible nursing home cuts and things that I can't imagine we would ever consider doing. Just with things that'll just be very harmful. Some of the old, reforms like 351 days and all that sort of thing, which is just going to cause great harm to the providers in a very challenging time anyway. And so, but in particular, putting the prepayment system across the board saves $167 million to the state, which the governor then has decided to go buy stuff with. The impact on the industry is $1/3 billion in a one-time shift, which they cannot absolutely absorb. And so I just wanted to caution everybody here, and I'm going to say this 10 more times perhaps by the end of session, we cannot take money from there and buy stuff here or anywhere else with that. I think that there's enough areas in this budget area that we could find ways to streamline, reform, eliminate some low-value programs to buy everything we have to buy, especially in the face of how large the budget has gotten. So thank you, Madam Chair. Appreciate that. And I'll do my homework. Thank you.
All right. Thank you. Thank you, Ms. Didion. Next, the Department of Health and MNsure are in document 26-08362. Are there any questions about the Department of Health or MNsure's proposal? Seeing none. Moving on, then we have the Department of Commerce. We have their proposal 26-08197, and that includes things that are not within our jurisdiction as well. So. What is within our jurisdiction is a proposal that has to do with HMO regulation. Are there any questions about that? And seeing none, I will move on. And I wanted to, I wanted to take this opportunity to mention we do have a quorum present. And so if there are no other questions about the governor's budget, we will move on to member bills. First, we will hear Senator Fateh, your bill, Senate File 3822. Good morning, Senator Fateh.
Good morning, Madam Chair. Thank you so much. And thank you, members of the committee, for allowing me to present Senate File 3822. Before I begin, I have an author's amendment for the bill, Madam Chair.
Thank you. That is in our packet. I'm just looking. Is that passed out? Just looking for the number. That is the A1 amendment. Senator Fateh moves the A1 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Fateh.
Thank you, Madam Chair. And the amendment was narrowing down the prior authorizations to just one drug due to a hefty fiscal note that we got, so just to work within the means. And so today we are talking about something very simple. When a Minnesotan is ready to begin treatment for opioid use disorder, The system should not make them wait. This bill removes prior authorization and step therapy requirements for the FDA-approved medication buprenorphine, which is the gold standard of care. This is also known as a medication for opioid use disorder. It helps reduce cravings, lowers overdose risk, and helps people stabilize their lives. But too often, when someone makes the decision to seek treatment, sometimes after months or years of struggle, they encounter an administrative delay, a form, a review, a waiting period, and in the context of opioid use disorder, delays matter. The window when someone is ready for treatment can be short. Relapse risk is high, and in some cases, delay can mean overdose. So prior authorization is not clinical care, it is paperwork. It does not improve medical decision-making. It creates friction for patients and providers alike, and it disproportionately affects those relying on public programs. Minnesota already recognizes that certain medications are too critical for delay. That includes protections for HIV/AIDS drug classes, but this bill applies that same logic here. If coverage exists, treatment should not be blocked by administrative hurdles. There are 22 other states that have taken steps to limit or eliminate prior authorization for medications for opioid use disorder because the evidence trend is clear. Reducing barriers improves access and supports continuity of care. So members, this is not a partisan issue. It is a public health issue. It is about moving red tape so people can access evidence-based treatment when they are ready. Delays are not working. So I ask for your support, and I have a few testifiers and letters of support from advocacy organizations as well in the packet. And thank you so much, Madam Chair.
Thank you. I just wanted to mention that, and if you did say this, I'm sorry, that the fiscal note is written to the amendment that we passed this morning. So if members have questions about the fiscal note. And we can go to testifiers. We have two on Zoom. First, we'll go to Kurt Devine. If you could please state your name for the record and begin.
Thank you, Madam Chair. My name is Kurt Devine. I'm a board-certified addiction medicine physician at Centricare Health System in St. Cloud. And much of my day is taking care of patients with opioid use disorder, of course. And I really thank you for this opportunity to testify on this bill. I think it's so important. And I think that it's important to point out that this prior authorization problem is not new. It's been a big issue, I think, in our offices for quite some time. But the disruption really to our office is really just the smallest part of this problem. It's really that delay that Senator mentioned that it takes to actually get these medications approved and get them administered to patients before they relapse or overdose or eventually die. Really, in the era of fentanyl, we have had to be much more aggressive and quick to act. We've used much higher doses, frequent dosing, and often transition these patients to long-acting injectable formulations of buprenorphine, which is frequently blocked by prior authorizations. So the requirements that leave our patients really underdosed, exposing them to potential harm as we wait for this, which I think is something we really need to improve. These drugs are readily available in our clinics and our pharmacies, and we really need to make sure that we can access them. For us, in addiction medicine, withdrawal from opioids and overdose and withdrawal after that Narcan is really the heart attack of addiction medicine. Every minute matters, and the sooner these medications are given and the patients are dosed appropriately, the less patient harm results clearly. There is very good evidence that the faster we get therapeutic dosing to patients, the better these patients do, and the less relapse and the less overdose and death. Just this last Monday, I had a young man, Native American man, in my clinic, and he was struggling and having difficulties and having compliance issues. And despite the understanding that he needed to take this medication, he was not doing a great job at it. And my first move was to switch him to a long-acting injectable. which I attempted to get prior authorized to give him that medication prior to him leaving my clinic. We were unsuccessful, and I had to let that patient leave my clinic with less than optimal treatment. And relapse is really the risk, and that risk of death. He was prior authorized last night at about 4 o'clock, and we are now trying to track him down to get him that injection. Often with addiction, we only have one chance, and it's important that when we have that chance, that we treat that patient and get them the help that they need. So I just want to say that, in summary, I'm just really asking for that support for SF 3822. I really think this can change lives, improve lives, and save lives. So thank you, Madam Chair.
Thank you. Next, we have on Zoom Jason Urbanchik, and I apologize if I mispronounce your name. If you could please state your name for the record and begin.
You pronounced it pretty good there. My name is Jason Urbanchik. Good morning, Chair Wiklund and members of the committee. Thank you for having me today. My name is Jason Urbanchik. As I said, I'm an executive committee member with Impact Minnesota for the Minnesota Coalition for the Homeless, amongst many other coalitions I'm a part of. I currently reside in Moorhead, Minnesota, and I'm here today because I've survived something that most people don't. I survived the wait. Let me tell you what the wait really means in the world of addiction. Wait looks like defeat. Wait looks like I'm never going to get help. Wait looks like a death sentence disguised as paperwork. Picture this. You wake up one morning in a rundown hotel. The same morning you normally wake up, you'd go use. But something inside you has shifted. You decide to try. You decide to fight. You drag yourself to a doctor at 5 a.m., waiting in line for hours, hoping you get a spot, shaking from withdrawal. You finally get inside, you're sitting in a room with strangers, and you confess the darkest parts of your life. You've done the hardest thing a person in active addiction can do. You've asked for help. If the doctor says, yes, I can help you, they write a prescription for medication that can save your life. For the first time in a long time, you feel a flicker of hope. And then you hear the words that kill that hope. Your insurance company needs more proof. It's going to be a few days, hang in there. Hang in there. Hang in there when your bones feel like they're breaking from the inside out, when your skin feels like it's crawling off your body, your brain is screaming for relief louder than any rational thought. Every second felt like punishment for trying to live. Most people can't hang in there. They go back to using, not because they want to, but because withdrawal is a kind of suffering most people will never understand, nor would you want to. Trust me. This is not a story I've heard. This is my life. I was forced to wait twice, and one of those times I didn't make it. I overdosed. I was that close to help and still dying on the floor. If someone hadn't have found me, I would not be here speaking to you today. Do you understand what this does to a person? To finally reach out for help and be told to wait? To be ready to live and be pushed back towards death? When someone is ready for treatment, that window is tiny. The window for the will to get treatment, trust me, it's even smaller. We can't pretend prior authorization is harmless. It kills people. Not in theory, not on paper, in real life. These outdated processes destroy trust in doctors, in systems, and in authority. People don't turn away from treatment because they want to be difficult. They turn away because they've been hurt, dismissed, or abandoned by the very institutions that were supposed to protect them. I've been in recovery for over 7 years now, and that is because the third time, finally, I didn't have to wait. Suboxone has saved my life. It gave me stability, dignity, hell. It's given me the ability to take control of my life and be the man that I am supposed to be. Doctors know what their patients need, insurance companies do not. It is dangerous and frankly irresponsible to let the insurance process override medical judgment in the middle of an overdose crisis. Minnesota has a chance to do something simple and profoundly life-saving, and prior authorization for methadone and buprenorphine. Let doctors treat and let patients live. I am standing here today because someone gave me the access to treatment without delay. I want every person in Minnesota to have that same chance, not just the lucky ones. Thank you very much.
Thank you very much for sharing your story with us. Next, we have Kimberly Price. Good morning. If you could state your name for the record and begin.
Kimberly Price. Thank you, Madam Chair and members of the committee, for the opportunity to speak about my support for SF 3822. My name is Kim Price, and I work as an RN for the public health clinic, for a public health clinic in a large metropolitan area, and I've been working in an MOUD exclusively since 2015. I want to speak plainly about the barriers that prior authorizations create and the real harm that they cause. Over the years, I've completed thousands of prior authorizations for MOUD alone. The hours spent navigating insurance restrictions are hours taken away from what truly matters, which is patient care, education, outreach, and the hands-on work that helps people stay alive. Prior authorizations don't just take time, they require persistence, specialized knowledge to advocate for a patient when the insurance company claims to know better than the provider who treats them. This is especially concerning because insurers often make decisions without understanding addiction medicine, without knowing our patients' histories, and without seeing the nuances of their symptoms, side effects, and those risks. We routinely battle with pharmacists or clinicians who haven't met our patients, yet they feel empowered to deny evidence-based dosing or insist on formulations that cause intolerable side effects or aren't the best choice for the individual. Every barrier increases the likelihood that becoming lost to follow-up, and in this population, being lost to follow-up can mean overdose and death. Treatment decisions should reflect the shared decision-making of the patient and their treating provider, not the insurance company who's a stranger. Our patients have experience with MOUD that's truthful, relevant, individualized, and that needs validation, not reputation, from care providers and insurance companies. We're missing critical opportunities to stabilize patients, and we're losing people who might otherwise have remained engaged into treatment. I want to address something that I heard in a previous hearing, which mentioned cost saving as a reason that this measure hasn't passed in the past. And removing prior authorizations for MOUD is fiscally responsible. As a nurse, we work hours and hours, and the clinicians have already made the decision to support the patient with the MOUD product that they need, and we will work to get that product approved, but it takes hours and a lot of delays. Most of the prior authorizations that we put through end up being approved because it's the correct course of action, and there's evidence to support those MOUD products and formulations and dosing. So I just want to urge you to move forward with the legislation that removes unnecessary prior authorization requirements for MOUD. Minnesotans deserve access to the medications that fit their needs when they need them without bureaucratic barriers that cost time, resources, and lives. Thank you.
Thank you very much for your testimony. Members, do you have questions or comments about the bill? Senator Mann.
Thank you, Madam Chair. Thank you, Senator, for bringing this forward. I find this fiscal note to be insane. And I just want to point to how perverse our healthcare system is. They said that once DHS stops receiving supplemental rebates on the brand name formulation of the preferred drug, they will be required to enforce a generic substitution, which will result in a new net cost. So we have created the system where we have to make sure that we put the most expensive drug on a formulary or as the preferred drug. And if we instead choose a cheaper drug, it costs more money for everybody else, except, of course, the PBMs and the manufacturers and everything. So we can extract as much money as humanly possible from the people who need treatment. That's the way the system is set up. It just blows my mind. So I do ask, anyone who's willing to answer, what's more expensive, paying for treatment of substance use disorder or paying for people not to go to work, people to go hungry, children to go hungry, paying for the foster system, paying for increased homelessness? What's cheaper? Someone just said this is the fiscally responsible thing to do, and I could not agree with you more. Paying for treatment is not only the fiscally responsible thing to do, it is the morally correct thing to do. So thank you for bringing this bill forward, Senator.
Thank you. Any other questions? Senator Utke.
Thank you, Madam Chair. And just a process question to this. Of course, with the fiscal note, we're talking only here about the state-paid portion of this coverage. Did this get set through for a mandate review so we know what the actual cost is to the plans and everything else? Because that basically is what falls back on the insured market, just so we'd have the numbers.
Senator Utke, this is only applying to medical assistance? This
Okay, so
bill
it's-
is only applying to medical
It's
assistance?
not being expanded to the
This
insured
bill is
market.
not, this bill does not apply to other markets.
Okay, that's what I was trying to find out here, so, okay, fine, thank you.
Okay, thank you. Senator Abler.
Well, Madam Chair, I'm going to miss Senator Mann being here. That was really a good speech, and I wish I could have said it better, but I couldn't, so thank you. It's madness. And we're here in the state, we're one of two bodies that's supposed to work on healthcare stuff. You know, the one across the street and then us, and we are so powerless in so many ways to even dent it, just while the tsunami of pointless bad ideas overwhelms us, and we spend more and more to get less and less. So that's my weaker version of the Senator Mann speech, but thank you.
Any other comments? No, seeing none. Thank you for bringing this forward. As I heard from public health, people who came and visited me talked about how this would just be a game changer for people who are out in the community, and they are meeting people where they are, and if they needed this, to not have to tell them, you know, you have to come back or you have to wait, would just be game changing. And so I really hope that we are able to do this in the future, and I am frustrated by the financial implications as well. But thank you. Any final comments, Senator Fateh?
Yeah, thank you so much for giving this bill a hearing, Madam Chair. This is really important. You heard not just from the letters and things like that you're seeing in the packets, but stories like Jason, who had a personal story, what it means to be burdened with the red tape and what delays can mean, and this can be life-saving. One of the pages in the packets show that how big of an issue access remains, and it shows that nationally only 17% of people with opioid use disorder receive the medications that they need, and to me that's heartbreaking. And so we got to remove the access to barriers to access whenever we can, and I think that this just makes sense. And I want to say thank you so much, Madam Chair.
Thank you. And Senate File 3822 as amended is laid over. And next we'll go to Senate File 8, Senator Boldon. Senator Boldon.
Thank you, Madam Chair. I will describe the bill perhaps first, and then I do have an A2 amendment, and I can talk about what that does as well.
Okay, thank you.
So appreciate you hearing this bill today. Minnesota is grappling with a mental health and substance use crisis that affects individuals across all ages and communities. As of February of 2021, 37% of adults in our state experienced symptoms of anxiety or depression. And that was in 2021. I can only imagine what that number is today. I guarantee you that it is higher. We also know that 80% of our counties qualify as mental health professional shortage areas, and only about 25% of Minnesotans needing mental health care receive effective treatment. Senate File 8 has bipartisan support because it stands to make a significant impact on mental health care in Minnesota by making the collaborative care model a reimbursable Medicaid benefit in our state. Collaborative care is an integrated approach to healthcare that focuses on treating common mental health conditions within primary care settings. This team-based model involves various health practitioners, including primary care physicians, behavioral health care practitioners, and psychiatric specialists,
all working closely together to provide patients with comprehensive care. This is an evidence-based model that improves patient outcomes, reduces costs, and empowers patients and their families. Every dollar spent on collaborative care saves $6.50 in reduced healthcare costs and improved productivity. This bill allows specified providers to bill Medicaid, establish sustainable reimbursement rate, and allocates grant funding for startup and training costs. Collaborative care is not just a theoretical concept. It's a proven approach that is currently covered by Medicare and nearly all commercial payers, with 38 states already offering it as a Medicaid benefit. In closing, the collaborative care model represents a transformative step towards comprehensive mental health care, and by passing this bill, we can help Minnesotans access quality mental health care and use our tax dollars more efficiently. In your packets, you will see a coalition letter of support from a variety of organizations, and we do have some testifiers as well. And happy, Madam Chair, if you want to address amendment before or after testimony, either way is fine.
Why don't we take care of the amendment?
Sure.
Senator Boldon offers the A2 amendment. It looks like that is the bill as you wish then?
Madam Chair, yes. I'll just say that the A2 includes language that makes it clear that the collaborative care services are not subject to cost sharing. HR 1 provides some exemptions for mental health and primary care services to be exempt from the new cost sharing requirements. And so the amendment just makes it clear that the cost sharing does not apply to collaborative care services.
Okay, thank you. Members, any questions about the A2? Senator Boldon moves the A2 amendment. All those in favor, please signify by saying aye.
Aye.
Any opposed? The amendment is adopted. And now we can go to your testifiers. I have Michael Trangle and is it Cassandra? Yes. Okay. And if you can state whoever wants to go first, I guess please state your name for the record and you can begin. And please make sure you have the microphone close. Yeah, thank you.
Thank you, Madam Chair. Thank you, members, for the opportunity to testify. My name is Frank Jadwin. I serve as Collaborative Care Program Manager with Hennepin Healthcare. Every day in Minnesota, patients walk into primary care clinics seeking help for their depression, anxiety, and substance use. Primary care providers deliver much of this care, including prescribing the majority of mental health medications, often without the support they need, and too often patients fall between the cracks. I will provide a brief overview of the collaborative care model and why this matters for Minnesota. This is a well-established, evidence-based model of care with more than 100 randomized controlled trials demonstrating improved outcomes across a range of mental health and substance use conditions, patient populations, and care settings. In this team-based approach, primary care providers partner with the behavioral health care manager and a consulting psychiatrist to deliver coordinated, measurement-based care. This matters because in traditional models, behavioral health and primary care often occur in silos. Patients are referred out to specialty care where many never connect due to long wait times, stigma, or limited access, particularly in underserved communities. In this model, patients receive timely, coordinated support where they already receive their care, avoiding delays and drop-off common in those traditional models. Patients work regularly with behavioral health care managers on focused treatment goals. That care manager consults weekly with a psychiatrist to review cases, clarify diagnoses, and make treatment recommendations. Progress is tracked using measurement-based care so the team knows when a patient is improving and can adjust their treatment plan when needed. Their recommendations support the primary care provider, who remains the prescriber and the center point of care. This model not only improves access and patient experience, but also delivers results. Research shows it is about twice as effective as usual care and reduces total costs by upwards of 13%. That is why Medicaid programs in 38 other states already cover this model. In Minnesota, we have the clinical expertise and infrastructure in place. What we need is the policy alignment to make this sustainable and accessible to patients who need it most. Thank you, and I'd be happy to answer any questions.
Thank you. And if you can state your name for the record and begin.
Madam Chair and committee members, thank you for taking the time today to hear about the collaborative care model. My name is Cassandra Sano-Hansen. I am the Behavioral Health Access Manager at Centricare. which is a healthcare system located just north and west of the Twin Cities metro area. For rural health care, the collaborative care model isn't just about innovation, improvement, or meeting the best contemporary standards of care. It's about how we will be able to meet the the psychiatric needs of our patients now and into the future. The collaborative care model delivers care more efficiently, keeping people with mild to moderate mental health and substance use issues in primary care, and reserving specialty care for severe cases that would benefit from the higher level of care. One example of this is a patient in our healthcare system who is experiencing some pretty significant health-related anxiety and would present to either our ED or our urgent care clinics, sometimes multiple times a week. What would happen is he would develop anxiety and start to really focus on those anxiety symptoms, and soon those somatic anxiety symptoms, soon they would turn into a rapid heartbeat, nausea, difficulty breathing, dizziness, and sweats, and he would start to believe that he was having either a heart attack or a stroke, and then would present to the emergency department where he would be medically cleared, and that would be quite comforting for him in those moments. And so we were able to utilize the collaborative care model to offer a source of comfort within that primary care clinic. So he could reach out to the primary care or the collaborative care provider and receive multiple brief contacts throughout the week, which were really targeting those anxiety symptoms, that checking behavior where he would go into the emergency department, and medication monitoring. This decreased his ED utilization, which meant less cost of care for this patient and also more beds available in our emergency department. In the handouts we provided, you'll find the information I'm about to share with you. According to the Health Resources and Services Administration, we currently have about 62% of the adult psychiatrists that we would need to treat our population, and 63% of what we would need for child and adolescent psychiatrists. And by the year 2037, even though we will see both an increase in need and a decrease in our psychiatric workforce for adults, leading to us being at about 40% adequacy, and for child and adolescent psychiatry, we'll be at 56%. Those are statewide projections. We know that our healthcare providers are not evenly distributed across the regions of our state, and that, as mentioned earlier, 80% of our counties are in designated health provider shortage areas for mental health. On the last page of the handout, you'll see that when it comes to psychiatry, 3 out of 6 of our Minnesota regions currently have a population to provider ratio that's more than 1.5 times worse than the statewide total. In the central region, where my office is located, we have 1 psychiatrist to every 20,845 patients, while the rest of the state, they have about 1 psychiatrist to every 8,282 patients. In other words, we have about 25 to 30% of the psychiatrists and APPs we would need in order to treat our region in the same manner as the rest of the state. And we anticipate that CentraCare will have 50% of its psychiatric FTEs in the next 5 to 6 years. Even though we've opened a new medical school and plan to expand the psychiatric residency program through collaboration with the state of Minnesota, we won't be able to train enough new psychiatrists to fill that gap either currently or in the future. Thank you for the opportunity to testify, and I'm happy to answer any questions you have.
Thank you. And do you have another testifier, Michael?
I believe so, Madam Chair.
Madam Chair, committee members, I thought I had gotten younger and better looking when I got called earlier. I'm one of those psychiatrists.
And if you could state your name for the record.
Oh, Michael
please.
Trangle.
Yes.
And I'm recently retired. She didn't mention, but we have a disproportionate number of baby boomers that are psychiatrists that are retiring. So our numbers are going down faster than they're going up. And I'm just going to give you one example. I had been doing collaborative care at 4 different clinics for about 8 years. And they can talk about the statistics. I just want to give you an example of how it's played out and helped one patient who is a very, very tough and struggling kind of patient. Mary was a mid-40s-year-old woman who was married, had 5 kids, was a stay-at-home mom. Her husband worked and was a very good provider, but they had some marital issues. He wasn't communicative enough, and she felt unsupported and kind of angry with him. Prior to her entering into our collaborative care management program, which was in a clinic in Bloomington, her primary care doc said, "You have chronic pain," did the whole workup, you know, x-rays, MRI, physical therapy, NSAIDs, and some other kinds of stuff, none of which seemed to help. And she was at the stage when we got in the picture of occasionally taking Tylenol number 3. And the occasions seemed to get a little more frequent. At the same time, she was complaining of depressive symptoms, insomnia, decreased energy, kind of hopeless, kind of negative. Wasn't suicidal, but just felt hopeless and kind of overwhelmed. Our case manager, who typically gets intake material and then does a lot of education with it, basically met with her and found out that the patient really just was so overwhelmed. She felt like she could hardly get up in the morning, you know, and respond to her kids who were having problems in school, and she had 5 kids. So what we did was we kind of saw what was going on and made some suggestions, and that included one, she said she was pretty anxious, and lo and behold, she was drinking 6 cups of coffee a day throughout the whole day, not following classic recommendations and not much caffeine after noon. And then she wasn't sleeping that well, and she was drinking 2 to 3 glasses, and I don't know how many ounces, if they were 3 drinks in one or just 1 4 or 5 ounce drink, to help her fall asleep. And we said, maybe you should tone down your coffee, stop it at noon, and gradually tone down the alcohol, and maybe give yourself a break from that, see how that's going. And did sort of the behavioral activation kind of activities where you kind of exercise, do a little bit of stretching, do some good social positive activities instead of being trapped at home with your kids and never getting out or having much support. I did some stuff with the medications to the primary care doc, switched to duloxetine, which should be able to help 2 or 3 of those things at the same time. But and we also said you should talk to a therapist. So the reality was, over the next couple of months, she somehow never quite connected with a therapist. She called one, they couldn't get in, another one didn't strike her well, and then once when the care manager was talking to her, she said, "I'm so busy, I don't have time for that. I have to return a library book today." Literally all she could come up with at that moment. She was taking her meds, I guess, which is an easier thing to do, but it didn't seem to be helping so much. So we were about 2 months into it, and it turned out that one night she was drinking and smoking in bed and reading, and she fell asleep, and the cigarette started a fire in her house, and her entire house burned down. The husband and the 5 kids got out, but she had bad burns and got hospitalized at the burn unit at the HCMC. You know, thank you for that. And we didn't know this. The care manager, one of the key things they do is stay in touch, follow along, make sure people don't fall through the cracks, that kind of stuff. When she didn't hook up with a therapist, she would talk to her and said, "What happened? Was it, you know," she said it wasn't a good fit. And then instead of letting it stop there, she said, "Well, let's look around and see if we can get a more compatible one." You know, part of that job is to stick with them and be persistent to make sure that they just don't disappear or give up or fall through the cracks. So the care manager couldn't get a hold of her. She tried calling, she tried texting, she did a letter, still couldn't do it. Now, when somebody enters collaborative care management, you sign a release of information so that the care manager and the psychiatrist and the primary care can talk to each other, can talk to the insurance company, can talk to other caregivers outside their system or clinics that they're in. So she was smart, and she said, I'm going to call the insurance company and see what's happening. And the insurance company had the release of information, and they said, oh, she's been hospitalized at HCMC. So then we reached out there and found out that she hadn't told her doctors there, and they even asked for a psychiatric consult. But she lied to the psychiatrist and said, I have no psych history, I've never seen anybody, I'm doing fine, you know? And we knew that wasn't the case. So then we kind of reached out to the family, the husband, as well as the people at HCMC, and said, we got to do something. This is so dangerous. She could have died in there. You know, it started in her room. She's the one that got burned the worst. It certainly wasn't an intentional suicide thing. But so we hooked her up, the family up, with a county case manager and pre-petition screening, and saying, you can't just walk out and do nothing. And essentially leveraged that admission where she did agree to go to a residential substance abuse treatment center, and they did family therapy as part of it and took her off all of her opiates. We coordinated with the insurance plan so that she only had one doc who was her primary care doc in our system, and that was the only place she could get any scheduled meds, any addicting meds, whereas before she had been secretly seeing 3 or 4 people and getting her Tylenol number 3 from all 3 of them. One of them also gave her oxycodone. So we kind of stopped that, and she did the work in therapy and struggled, and she got out, and how do I want to say this? She and her husband ultimately didn't work it out, although they had some family therapy, it didn't work, and they got divorced. She improved her relationship with her kids. She went back to school and got educated and ultimately got a job working for NAMI.
And if you can kind of
the process
conclude your
worked,
story,
basically.
I would appreciate it.
Okay, that's all. It's just an example to give you a flavor for how it works.
All right, thank you. Members, do you have questions or comments about the bill? Senator Abler.
Well, thanks. Just the fiscal note, is that still accurate? That we're going to spend a bunch of money to save money, or is that?
Well, I know last year's fiscal note.
Mr. Triangle, I'm sorry.
Wasn't to me.
We need to, the fiscal note reflects the original bill, and they're working on it. Senator Boldon, maybe you know the status of the current work.
Thank you, Madam Chair. We have requested an expedited, a new fiscal note. I have not yet seen it.
Yeah.
Senator Abler.
Well, I'm channel Senator Mann again on this one, but it seems like 6-to-1 savings, and I have been so frustrated sitting in that middle seat and in this seat here as we do things that we know will save money, and the department just cannot comprehend that that would actually be useful, and that's not even dynamic. If you don't do something, you don't have to pay for it, and if you do something that's cheaper, then it should cost less. And so, with all respect to my good colleagues at the department, I don't know why this wouldn't actually be a savings proposal. So I hope it can be. Otherwise, Madam Chair, we're doomed. We're going to spend more money to do things worse, you know, the Fateh bill and all that. So anyway, I just leave it at that. But I'm not even begging for dynamic fiscal notes. I'm just looking for reasonable fiscal notes that take into consideration what really happens, the chiropractic fiscal note. Let's take it all away and pay for no replacement services. So we save 20, but we're going to spend 40, and that gets counted as a $20 million savings. So anyway, thank you, Madam Chair.
Any other questions or comments? Senator Boldon, any final comments?
Just a thank you. I mean, I agree. I mean, part of the reason to do this is certainly savings. It is a smart investment. It does create savings that, you know, as I said, $1 invested is $6.50 in reduced healthcare costs down the road. But the bigger reason to do it is because of the patient outcomes. It really is the right thing to do for patients. And in a time when we have, you know, a shortage, 25% of Minnesotans are getting the mental health care that they need. We have to start being innovative and looking at other ways to do this. And this is not even a new thing. You know, many other states are doing this. Private plans are covering this. As a state, we should cover this with our Medicaid dollars as well. So thank you.
Thank you very much. And members, Yeah, this bill will be laid over. Thank you for bringing it forward, Senator Boldon. I think it does make sense, and we should really be seriously considering how we can make use of the providers we have and make sure people have access to care they need in a better manner. So thank you, and Senate File 8, as amended, is laid over. Thank you. And now we will move to Senate File 3705, Senator Mann.
Madam Chair,
Senator Abler.
just filling in the gap here. I just was reading the department bill, and it suggests that forecasted programs will be reduced by $233 million in this document. And it's not a forecast adjustment, so the impact, I just want to caution people, this is, in this committee's little piece here is the equivalent of like $400 million of changes. And so just, I'm not going to be in the meeting where you sit and decide what to put in the bill, but there are many things in here people would want to testify on, not to try to get rid of once you stick them in. So I know you're a very inclusive chair, and when the people have concerns, you'll listen to their concerns about this prose that's in the bill, which we've not had opportunities for people to testify about. So thank you.
Senator Abler, just a comment. We did allow for written testimony about the bills, all of the governor's proposals, and those were posted, and there were just 4 of them. So, I mean, we are giving opportunity. And then, of course, if we do include proposals, we will take testimony on that, that bill when it comes out, so.
Chair, I'm just
Senator
worried. I mean, I'm not doubting anything about you. It's nothing, it's just, I know the process. Oh, we need some money. Oh, here's some money. It's a bad idea, but we need the money. And I've been in too many of those meetings, so I just want to make sure before everybody gets excited about what they get to buy, that to make sure where it came from. And right now, the whole human service side of things is in terrible turmoil. So that's all. I'm just offering that now, and we'll talk about it in a week. So thank you, Madam Chair.
Right. Thank you. Senator Mann.
Thank you, Madam Chair. Minnesota is facing a very well-documented mental health provider shortage. Families across our state are experiencing long wait lists, limited provider choice, and in some cases, no available in-network mental health care at all. During the period when Minnesota's Any Willing Provider Law was in effect, mental health providers who met credentialing standards and were willing to accept standard contract terms were able to join insurance networks. When that temporary law expired, at least 2 major insurers began denying contract requests from mental health providers, despite ongoing shortages and unmet needs. When insurance companies refuse to contract with willing and qualified providers because of administrative burden or increased cost to the insurance company, of course, it is the patients who bear that burden. So Senate File 3705 simply removes that sunset date and puts the law back in place. Happy to move to testifiers, Madam Chair.
Thank you. And we have first, I'd like to call up Jason Roman and Andy Kerr. And Mr. Roman, if you could state your name for the record and begin your testimony.
Yeah, my name is Jason Roman. Thank you, Madam Chair and the committee, for opportunity to testify on this important topic. I'm a licensed professional clinical counselor and licensed alcohol and drug counselor. I run a small clinic here in the Southwest Metro. We specialize in co-occurring disorders, which is just basically helping people manage the combination of mental health disorders and substance use disorders. I'm here because, as Senator Mann just mentioned, there's a Minnesota workforce shortage. I'm trying to hire clinicians right now to expand access, but insurers have prevented me from doing exactly what we're saying we need more of here. Not every clinician is trained to help clients with co-occurring disorders, which is why clinics like mine have historically been able to kind of petition and try to get contracts, but that's not happening now. They're simply just saying, due to network saturation, we're not taking more, we're not offering more contracts. So the Minnesota's 2024 Behavioral Health System Review showed our mental health and substance use workforce was already severely strained, and that was with the Any Willing Providers Act still in place. So if we were strained then, blocking this just continues to add to that strain of being able to add more counselors to the field. My clinic's ready to hire, like I mentioned. We have clinicians who want to join us, but every time I have a conversation with a potential clinician, I have to let them know that I don't have a health partners contract, which makes it really challenging for me to hire someone if they can't, their clients can't come along with them to my clinic to be cared for. The denial is not based on quality of care or safety issues or anything like that. It's simply based on insurance companies saying that they're full and that they have enough people. Before the statute expired, like I mentioned, if you had a specialized population, you could at least make the case that a contract was needed. I personally, thanks to Flourish Business Solutions, who's here today, I personally got some inside communication with a member at Health Partners who was supposedly a decision maker, and that person just simply repeated back every time, our network is full. They weren't interested in hearing about the need in our community. So instead of adding clinicians to the workforce and reducing wait times, I'm telling clinicians they can't work for me because the network is full. There's a workforce shortage. This is an access problem. This is just, it's a bottleneck created by policy, essentially. I've been talking a lot about my clinic, but essentially it's really about the clients, and they feel this when they can't follow their therapist to a clinic. When they become independently licensed, they can't get a contract, they can't follow their therapist. You heard some testimony earlier about substance use disorders and how dangerous it can be for clients when they can't get the care that they need, especially from specialized providers. So basically, local clinics like mine provide stable community-based care, but when networks close, the clients get pushed toward those large national platforms, simply because those platforms hold the contracts. This weakens local access and continuity. So I just want to finish by saying continuity of care should not depend on whether an insurer decides they have enough providers. This statute ensures Minnesotans can keep their therapists and that clinics like mine can keep building the workforce our state needs. Thank you for your time.
Thank you very much. And now, Mr. Kerr, if you could state your name for the record and begin your testimony.
Good morning. Thank you, Madam Chair and committee members. My name is Andy Carr. I'm a licensed marriage and family therapist in Minnesota. I own and operate an outpatient mental health clinic called Sparrow Wellness of more than 20 clinicians who serve clients from all across the state, either in office in Burnsville or St. Paul, or via telehealth, even in outstate Minnesota. When I originally became licensed in 2014, I sought in-network status with multiple health plans in Minnesota and was told the same thing, that their networks were saturated in the Twin Cities. And even though I served clients statewide in outstate Minnesota, which we've heard so far this morning, has an even greater need for providers than the Twin Cities, even still, their network was saturated and they would not give me in-network status. At the time, I was also involved in a peripheral way with the Minnesota Association for Marriage and Family Therapists, our Association for Professional Growth and Development. I found out that South Dakota in 2014 had a similar piece of legislation as we're discussing this morning, an Any Willing Provider law that gave contracts to any provider who was who held the correct credentials and was willing to take network rates. So in the fall of 2015, I advocated with the MAMFT to essentially lobby the state legislature to put that law on the books. I tell you all this to say that I've been aware of this type of legislation and working towards its passing for over 10 years. The problem with access is not a new problem. Many have testified to that already. I have 5 clinicians on my team right now that, due to a specific contract addendum being blocked, cannot see clients even though I have in-network status with a specific payer. When I asked the specific payer how they were going to meet their own self-published definition of a provider gap of 250,000 additional clinicians in 2025 from their published gap from 2023, how they were going to fill that gap by denying contract requests, I got the same verbiage, the same boilerplate, the same standard line that the network was saturated and they weren't taking anybody at this time. I've found some national data. I know you've heard from Minnesota, some Minnesota-specific data. As baby boomer providers start to retire, this is going to create, this is the health, the HRSA projects the following labor shortages over the next 10 years. We've heard already about the psychiatric labor shortage nationally, a net loss of 56,000 psychiatrists, a net loss of 33,000 marriage and family therapists, a net loss of 99,000 mental health counselors, and a net loss of 99,000 psychologists, and finally a net loss of 27,000 social workers. I understand fraud is a big concern, and I share that concern. I'm confused as to how we're solving a fraud problem by denying contracts to providers who are willing to take network rates, who are willing to be in compliance with payer regulations. And it doesn't seem to make sense to solve a problem with a different problem. Thank you.
Thank you very much. I also have Britta Sveil, I'm sorry, if you could come forward.
Good morning.
Good morning.
My
If you
name
could
is
state your
Britta
name.
Seville. You did pretty good. Good morning, Madam Chair and all members of the committee. Thank you for allowing me to be here today. I am a licensed professional clinical counselor and also a licensed alcohol and drug counselor. I am here today on behalf of the Minnesota Counseling Association and also as the owner of a small group mental health practice in Maple Grove called Degas Therapy, where we serve roughly 150 clients each week. As stated multiple times already, Minnesota is facing a significant access mental health crisis. According to NAMI, more than 226,000 adults in our state report needing mental health care but not receiving it, and over 2.1 million Minnesotans live in areas without enough mental health providers. Additionally, 80% of Minnesota counties are designated as mental health professional shortage areas. There are mental health professionals in these areas. What we are seeing on the ground is that this is not just a workforce shortage, it is also an access problem created by insurance contract barriers. The Minnesota Counseling Association recently surveyed licensed counselors across the state. The findings were very striking. A large majority of respondents reported being denied or significantly delayed when trying to join insurance panels, even after becoming fully licensed and meeting all credentialing requirements. Providers described the process as opaque, inconsistent, and extremely difficult to navigate. As a result, clinicians are being forced to turn clients away. One counselor shared, rural areas will languish without more choices and sustainable practices. Another said, clients everywhere are experiencing wait lists, especially for children and adolescents. And another explained, many clients build rapport with therapists and find starting over so daunting that they just choose to go without help. This is the real world impact of restricted networks. At the same time, we are seeing increasing consolidation in our healthcare system, with insurance companies moving towards large, integrated systems of both providing insurance and care delivery. These shifts are changing the landscape of mental health care, reducing access for clients, and pushing small practices out of operation. Independent providers and small practices who often offer more flexible, personalized, and relationship-based care are finding it increasingly difficult to access insurance contracts. One survey respondent put it this way: there is no way to open a private practice without losing the majority of my clients. Another said, it shouldn't be this hard to make a living and provide good care. These are not just business concerns, these are care concerns. When providers cannot access insurance panels, clients lose choice, wait lists grow, continuity of care is disrupted, and clinicians experience burnout and financial instability. SF 3705 offers a practical solution. It does not lower standards. It simply ensures that qualified providers who meet credentialing requirements are able to contract with insurance companies and serve clients who are ready to use their benefits. In a state where hundreds of thousands of people are still going without needed mental health care, we cannot afford to keep willing providers out of the system. Decades of research have proven that the therapeutic relationship is the single most important factor in the success of psychotherapy. Choice is paramount in that important factor. Finding a therapist where that is possible in our own chosen communities is a wonderful gift that we as mental health providers can offer to our communities. Therapists make our communities healthier. On behalf of the Minnesota Counseling Association, I urge you to support SF 3705. We also welcome you to review the feedback provided from our members, which is attached to our letter of support. Thank you for your time and for your commitment to improving mental health care in Minnesota. Thank you.
Thank you very much.
Yes, thank you.
And lastly, I have Danielle Deschano. Welcome to the committee, and if you can state your name for the record and begin.
Thank you for having me here today. My name is Danielle Deschano, and I am the CEO and founder of the Remedy Mental Health. The Remedy Mental Health offers interventional psychiatry, substance use disorder care, as well as perinatal psychiatry services within 4 locations across Minnesota in all 4 quadrants of the metro area. And we do serve approximately 10,000 Minnesotans today through telemedicine and in-office visits. We also have locations in South Dakota and 2 in Wisconsin. I'm here today to be a voice for some of Minnesotans' most vulnerable patients, those suffering from severe mental illness and substance use disorders. I opened the Remedy after supporting my son through a severe heroin use disorder. During that time, we faced closed doors, long wait times, disjointed care, and at times nowhere to go. That experience led me to build a practice focused on access, compassion, and evidence-based care without barriers to judgment, because that very system nearly ended my son's life. Last August, and I think all of you are going to be surprised by this, after hearing everybody's testimony about lack of access, Health Partners informed us that they would not be renewing our contract in January 2026. Since then, we've been devastated by the impact of our patients, many of whom, and I'm going to get emotional, struggle with treatment-resistant depression, suicidality, and addiction. I've had to support these patients through this. For what reason? They've experienced denied continuity of care, referred to practices that no longer are open, referred to inappropriate practices that don't offer a team approach, referred to providers that have greater than an hour away from their home, referred to practices that don't offer service the patients need. These patients are devastated. They've gotten the rug pulled out from underneath of them, and they have nowhere to go, even though Health Partners says, we've got them. It's just not true. They have waivers that they've had to sign, or they have waivers for access of care, waivers with the state of Minnesota saying that we know, Health Partners knows that they don't have access for these patients. We're told behavioral health navigators, we've got them. We're going to lose patients. Patients' livelihoods are going to end. Patients who are back to work, back having their kids from foster care, that's going to change for them. And there's no reason for that. Authorization for continuity of care is not equitable for our members. Some were denied, some received 4 visits or 4 months, others received 16. This has caused significant harms to patients, and their options are extremely limited, many of which had Medicaid insurance without any out-of-network benefits. With Utke closing, this limited patients even further, limiting just 3 health plans for Medicaid patients: Health Partners, Blue Cross Blue Shield, and Medica. Take this a step further. A lot of private practices don't accept Medicaid because they've met their quotas. That's not us. We accept everybody in all Medicare Advantage, Medicaid, it didn't matter. We were here to care for people. In mental health care, the provider relationship is everything. Trust takes years to build. Disrupting that relationship doesn't just interrupt care. It can undo years of progress and place patients at serious risk. In South Dakota, where any willing provider law exists, this type of disruption did not occur at a Rapid City location. That contrasts why SF 3705 truly matters. When health plans narrow networks without oversight, it reduces access, limits choice, increases costs, slows innovation, and removes accountability, often through not-for-cause terminations that lack transparency. At its core, this is about patient safety. Many of these patients will not call your office. They won't testify. They're just fighting to get through their day. But I can tell you this, when access to care is taken away, people don't just get worse. Some of them will not survive. I urge you to support this bill, and I thank you for your time, and I'm happy to take any questions you may have.
Thank you very much for coming to testify. Members, do you have questions? Senator Liskey.
Thank you, Madam Chair. Senator Mann, I want to thank you for bringing this bill forward. There's things that you and I agree on a lot of times, and networking is definitely one of the issues that I see as a problem, not a solution. The bill that you're presenting, it's an interesting way to try and work through the networking issues that we've seen in the community, specifically around mental health, but it's not just in mental health. We know networking is having issues across all health professions. I want to mention a bill that we're working on that I'm working on with another colleague that does similar things but changes maybe the approach, and I just want you to look into it, maybe get interested, because I think it does a lot what this is trying to do but in a different way. Senate File 5024 was just introduced, so I'll let you write that down and check into it. We are naming it the Universal Access Plan, and the reason why is because the networks seem to be being abused as opposed to being used the way they were supposed to be, right? Originally, networks, I could argue, were created so that we didn't have fraudulent behavior, as mentioned during some of the testimony. Now I feel like networks are being used to control access to healthcare, and it reduces their cost on their side instead of on the patient's side and the proper access to healthcare as described by the last testifier. I've been pushed off networks. I've had to go through hoops to get on networks as a provider myself. I've had networks tell me that they don't really care that I am not getting paid even Medicare rates, which is a federal law, last I checked. They don't care, and it's frustrating. And so I understand the purpose of the bill. It's not necessarily how I would go about it, because as a provider, I don't want to have to get into these networks. Some of these networks are abusive once you're in them, so it's just as problematic. So that's where I think the approach that we're trying to go through is maybe a little bit better. I hope that you can look through it. I still appreciate this bill. I can understand what you're trying to do, and I look forward to having more discussions with you. Thank you.
Thank you. Senator Boldon. Oh, I'm sorry. Senator Boldon.
Thank you, Madam Chair. I just want to say thank you, Senator Mann, for bringing this bill. You know, sometimes I sit here and just, I'm a little mind blown of the conversations that we have and the work that we have to do. You know, we hear from providers who say, like, we just want to care for people. Quotes from providers who say, rural areas will languish without more choices and sustainable practices. 25% at least of Minnesotans don't have access to the mental health care that they need. Millions of people in Minnesota live in a community without enough mental health care professionals. 80% of Minnesota counties qualify as mental health professional shortage areas. We get all of this data and information about how there is not access, there is not enough care. Providers who just want to take care of people, and then Minnesotans, our constituents, and people come to committee and say, can we just get care? Like, can somebody just get me access to care? All of this comes before us, and then we have to take these little baby steps to fight insurance companies to allow care for people. All of the barriers they create, with this bill creating barriers, with the previous bill we heard about prior authorization, it is barrier after barrier after barrier for people to be able to have the care that they need and deserve. And it is infuriating. And I so hope that we can continue in this committee to work towards systemic changes to change that system so that it is not focused on profits and the care for some, but truly care for all. And it is frustrating is not even the best word, but is the word that's coming to me now. It's infuriating that we have to have the discussions, that we have to take little baby steps to get a few more people the care that they deserve. So this is a good thing, and we'll do some of that. I look forward to doing more of that work to be sure that we get to a better system that really is focused on care for people. So thank you.
Thank you. Senator Abler.
Well, thanks, Madam Chair. You just insert speech number 25 about the ridiculousness of contracting. I've been talking about this since I have been here. Contracting exists to limit access for people to have access to the care they need. It's especially given the testimony here by every testifier, it is is absolutely wrong. I support the health plans to do what they do, but they are wrong on this. And so if you can have a limited network, then 10% can't get what they want, you save 10%. You know, and people die, and well, that's just, it's an economic standard. I had a chat with, well, I'll use the term, an Alina executive, talking about the nursing staff that they have there. And they have a 40 percentile level of staffing. And so, and I said, well, that seems like a horrible number. You should at least 50% as average. And he talked about, well, it's actually maybe even going to get better. And so better in their view was under 40, like seriously. And as I talked to the Alina nurses, they feel overworked and they can't give the care they need. But anything that saves money is good. And I just don't get it. Senator Mann, you and I diverge on whether we should have health plans or not, but it's hard to defend them when they do this kind of stuff. And especially now with people $30,000 sometimes into first dollar coverage. They pay $20,000 and then a $10,000 deductible. What the heck are we doing? And the people who come representing the health plans, they are really nice people. They have families, it's their job. But the people I would talk to are the boards of directors who sit in those offices. And then they say, oh, we're losing money. You know, Blue Cross, we lost money, we lost money. There's too much admin, there's too much middle management. You look across the world at what other countries do, and they have way less people between the payer, the premium payer and the doctor. I just was picketing one day with the doctors. Are doing it so well in Coon Rapids that they have a union. So they charge $200 and they get $40. What the heck? And in the name, oh, but we need a network to make sure we don't have overuse. The health plans can always go back. They can claw back stuff if they think I billed it wrong, and they do once in a while. So there's no fraud issue here. But it's madness, and I don't even know what to do. So I give this speech, like I said, speech number 25. I'm gonna give it again next year if I'm fortunate to come back. And I don't understand, and nobody cares. And in the ethics of healthcare, we are blowing it. And if you want to take the good people here representing the various plans, take it back to your boards and decide, is there some place in ethics in medicine at the top there? And there's just too many staff, too many people overseeing, too many fingers in the till that accomplish nothing with quality care. And it should be reinforcing the good work of these good clinicians here. So I only had one cup of coffee today, Madam Chair, so it's not bad. Thank you.
Thank you, Senator Abler. Any other questions or comments? Well, Senator Mann, thank you for bringing this forward. I too am very, I don't know, more than frustrated with the insurance, these contract barriers, and they are absolutely blocking, you know, patient access to the care they need. And it is not, to me, a reasonable response to say we can't have this provision, and it had to be time limited. So I don't see evidence that it hasn't been presented that taking, you know, out the sunset on this provision that we put in place. And at the time, you know, it was stated maybe this is a temporary thing, but I don't see evidence that it has been a problem, a negative. There's not been evidence brought forward that it has been negative. And I can absolutely see that with the removal of this provision, that providers are facing these really difficult barriers, and that's translating into, you know, real negative impacts on patients. So any final comments?
Thank you, Madam Chair. I just wanted to quickly agree with my colleague here that the rest of the world does indeed have less administration and less middlemen. The rest of the world has some form of universal health care. And I would also like to highlight the people who testified today, people who have dedicated their lives to helping other people, people who are dedicated and invested in their patients, and are now fighting insurance companies to provide the care that they are willing to provide to the patients who need it. This is just yet another example of insurance companies trying to increase their profit margins by denying people care, which is a very well-known profit engineering model in our healthcare healthcare system, Madam Chair, and we should not be complicit in that any longer. Thank you.
Thank you. And Senate File 3705 is laid over. And now we will move to Senate File 4933.
Before us is Senate File 4933. Go ahead.
Thank you, Madam Chair. Let me get my notes. Thank you for hearing Senate File 4933 today. This is a continuation of a conversation that we had last year around increasing outpatient mental health reimbursement rates under medical assistance. In this committee last year, we heard from mental health providers across the state about the treatment access crisis we have in Minnesota. We heard about adults, children, and families waiting weeks, months, or in some cases years to access the care they need. We heard about children with mental health challenges boarding in a hospital, juvenile detention, or with the county because families have lacked access to early intervention and intensive community-based care. We also heard about mental health providers shrinking or closing services because hiring and retaining staff was close to impossible. And finally, we heard about the large and growing gap between the cost of providing care and our Medicaid reimbursement rates. So we took action. We passed a bill into law that leveraged a federal funding program to draw down additional Medicaid dollars to pay for needed rate increases. We were successful in passing that bill in special session last year. And then H.R. 1 passed. H.R. 1 changed the federal program and took away the funding mechanism we designed. So this year, we're back to trying a different funding approach. My bill uses general fund dollars to pay for rate increases in two important areas we talked about last year: repealing the master's level cutback and increasing reimbursement for psychological testing and assessments. The repeal of the master's level cutback recognizes that mental health professionals should be reimbursed the same rate for providing the same service within their licensed scope of care. This change is one of the most significant investments we can make in mental health care delivered across the state. And increasing reimbursement rates for psychological testing and assessments is a critical step in ensuring Minnesotans have access to timely diagnoses, needs assessments, and corresponding treatment and community-based services. These assessments help people who struggle with learning problems, attention concerns, autism, trauma, just to name a few of the conditions. They are a key component of a 504 plan or an individual education plan that supports kids in schools. They are also a key access point to developmental disability waiver services, and there are no county resources for these assessments. I've heard from many providers that their wait times for this testing are over a year long. That's easily over 1,000 kids and their families who are waiting. Can you imagine needing mental health care for your child or loved one and having to wait a year just to get initial answers to help determine next steps? Last year's bill included these exact same increases along with several others. I'm hoping we can make this investment this year, and then future legislatures can continue making investments until we have realized what we passed last year: increased reimbursement rates across mental health services. And now I'd like to turn my testifier, Jinli Palin, to just further describe the need for this regulation or this legislation.
Welcome. Please introduce yourself and proceed.
Thank you, Madam Chair and members. My name is Jinli Palin. I'm with the Minnesota Association of Community Mental Health Programs. We are a state association representing the community mental health programs and the certified behavioral health clinics across the state. We are also a very active core member of the Mental Health Legislative Network. And I will be very brief because I don't want to duplicate what Chair Wiklund already stated, and I think you all are very familiar with all of the work that has been happening around the conversation for our Medicaid rates and mental health services. I want to start by saying thank you so much to the committee, to all of you, and to the legislature for the work that you did last year in passing the larger reform package to improve our mental health Medicaid rates last year. As Chair Wiklund noted, unfortunately, our friends in CMS and in Congress eliminated our ability to pay for those rate increases through the mechanism that we had passed, and so we are back this year. I might just speak very quickly to the two components we are trying to move this year of that larger package. Repealing the current cutback for any clinicians who are educated at a master's level is really about ensuring that these independently licensed clinicians are able to be reimbursed at the full allowable Medicaid rate rather than a discounted rate for the services they are providing as independently practicing clinicians in our space. This ensures that all of our precious limited clinicians are able to practice at the top of their license, and it will bring a really positive investment across the majority of our Medicaid mental health system. Secondly, to the psychological testing needs, I think Chair Wiklund stated it very well, but increasing psychological testing codes to at least 100% of Medicare will really address the very real wait lists and inadvertent delays in services that have been created through lack of access to these testings, especially for families and children most in need. And so with that, we are very much encouraging, and thank you for hearing the bill. We hope you support Senate File 4933. Thank you.
Thank you. Members, questions? Seeing none, we'll lay this over. Thank you. Next is Senate File 5047, which will be was introduced today. So we cannot hear it today, so it'll just be an informational hearing.
Thank you, Madam Chair. Senate File 5047 is one of the proposals that we will be discussing that have to do with addressing hospitals and other healthcare entities' needs in terms of providing relief for uncompensated care costs. And so the bill has a couple different parts, or I guess more than a couple. But one is a hospital-focused uncompensated care relief program. The second is, Section 2, is a community-based safety net provider uncompensated care relief program. And then there is also recognition that our EMS system is suffering from uncompensated care issues as well, and there's a uncompensated care pool payment program for EMS. And what I'd like to do is have my testifiers come up because they will be able to speak to each of the aspects of this bill and what it is designed to address. So.
Very good. We have Michelle Benson, followed by John Fox.
Welcome. Yeah, you could.
Well, we can go ahead and start with Mr. Fox. Since you're there, go ahead, introduce yourself and proceed, please.
Okay, sorry about that. All right, thanks for having us here today. My name is John Fox. I am currently the director for Dodge Center Ambulance in southeast Minnesota. We are a small, we run, about 1,400 runs a year service, and we work in a predominantly rural county. We did 1,370 runs last year, which was a 9.3% increase year over year. One of the big factors that it's impacting us and why this is so important to me is one of my biggest sources of being able to stay open is my very, very dedicated volunteer staff. I received about 20,000 hours of donated labor last year. That is a replacement value if I had to pay those people $600,000 plus a year. We're getting that. That is what is sustaining us to getting out the door to serve our public. So with an increase in runs, more specifically to what we're talking about here today, is 309 of the responses last year did not result in a transport. Of those, 229 had a patient contact and an assessment without a transport. 12% of those, just real quick data I pulled yesterday, 161 of those, so 12% of my runs last year were totally uncompensated, even though I had a patient contact, did a full thorough evaluation. We either determined or they decided they did not want to be transported. And so that is if I were to able to have been paid even the Medicare base rate, is about $76,000. So that's money that we just aren't getting. I don't have access to. We don't transport, we don't get paid. So I am tacitly, at the very least, incentivized to transport, because if I transport, we get paid. Well, if I do that, it's wrong for the patient, it's wrong for the emergency department overloading. We're adding in all of those additional costs and fees. Yet I am required by law to respond and provide that care, and nobody's paying us for that. So we're pretty frustrated. So we are really, really thankful for all the work you guys have been doing the last several years. There is a small uncompensated care pool. I just got information from the Office of VMS this morning that the applications were submitted. We had all but 15 services did submit to that pool, which is not going to come close to what we actually need, but at least there's something. And I would argue that those 15 are probably in a similar situation to me, where they're so busy trying to get a truck out the door, covering service calls, trying to do those other things, that they just didn't have time to go through and dig through all the data and submit all that. So those are the kinds of things that we're being faced with. And so if we do the right thing for the patient, for the emergency department, for everybody involved, and then we don't get paid for it, we're not getting compensated. So I continue to rely on the very, very goodwill of our volunteers that are doing this work. And that's just not reliable, realistic, or sustainable. So I do appreciate everything that you guys have done in the last couple of years, and we're trying to get the job done, and we just need some help with that. Thank you.
Thank you, Mr. Fox. Ms. Benson, welcome. Introduce yourself and proceed.
Thank you, Madam Chair and committee members. I appreciate the opportunity to testify on behalf of the Minnesota Hospital Association, our 139 hospitals and health systems. We are proud to provide 24/7, 365 care to Minnesotans in need, regardless of ability to pay. Senate File 5047 is more than a request for support for Minnesota hospitals as we face growing challenges. It is an essential lifeline to healthcare organizations whose mission is to be there for every patient, regardless of ability to pay. We are partners in care, and we are partners in this request. Patient care in Minnesota hospitals is at risk. Over 30% of our hospitals are already operating in the red. We face rising costs for drugs, skilled staff, and supplies. Government programs do not cover the full cost of care, and charity care demands continue to grow. In 2024 alone, the last year for which our audited financials are available, hospitals invested $2.6 billion of their resources simply to cover losses from underpayments and uncompensated care. On Tuesday, thank you, the Senate demonstrated support for the 340B program, which is an existing program that allows us to stretch scarce resources for patient care. Even with that important step towards stabilization, things are about to get worse. As Madam Chair mentioned, last year's bipartisan statewide directed payment program may be scaled back by CMS. Medical assistance redeterminations and work requirements could leave more than 140,000 Minnesotans without coverage. Rising out-of-pocket costs will push even more people into the uninsured or underinsured status, increasing charity care demands. Combined, hospitals are facing historic increases in uncompensated care. We are here today to request one-time funding that will provide targeted relief as this burden grows in the year ahead. Senate File 5047 creates a hospital uncompensated care relief program. This bill is structured to disperse funds with minimal delay based on documented uncompensated care for uninsured patients. Qualifying episodes at the hospital are limited to high-cost services ranging between $5,000 and $50,000 per patient encounter, services that would be eligible for medical assistance payment if the person had been eligible. Hospitals will apply twice a year. Payments are distributed proportionately based on each hospital's share of the statewide total, with no hospital receiving more than 10% of the funds in any 6-month period. Half of the annual appropriation is allocated in each reporting period with payments issued by the following November and May. The program is intentionally scalable and flexible. As the budget process continues, we'll work with the chair, members of this committee, and the Finance Committee to refine the list of qualified hospitals, the payment range, and the caps to balance the very real headwinds that our hospitals face with state budget realities. This targeted relief directly addresses the growing charity care burden and helps keep our nonprofit hospitals financially stable so they can continue providing 24/7, 365 access to care for every Minnesotan who needs it. Thank you for your consideration, and Senator Wiklund, we want to thank you for your partnership and dedication to the stability of our healthcare system. Thank you.
Thank you very much. I'll call forward Pahua Yang and Sarah Torres. Ms. Yang, if you can introduce yourself and proceed, please.
Good morning, everyone. Chair Wiklund and committee members. My name is Pahua Yang, and I have the privilege of leading the Community Mental Health Division at the Wilder Foundation. Wilder is the oldest nonprofit in St. Paul, and we've been providing mental health services for children and families since 1924. In 2017, we became one of the first 6 certified community behavioral health clinics in Minnesota. Even in the context of more than 100 years of change and growth, becoming a CCBHC stands out as the single greatest improvement in our ability to meet the needs of children, adults, and families. As an essential safety net community provider, we serve clients and communities who would not otherwise have access to mental health and chemical health care. We serve more than 3,000 families every year in our mental health division, half of whom are children and adolescents. CCBHCs are part of a model of delivering integrated behavioral health care to Minnesotans. Originally built under a federal demonstration a few years ago, you passed legislation to transition this model into a covered benefit under medical assistance. With the anticipated implementation of H.R. 1 provisions, our clinic's uncompensated care will increase drastically as individuals we serve are denied or disenrolled from Medicaid coverage. The Community Mental Health Center model was designed to provide access to critical outpatient and community-based care when the state closed its mental institutions and hospitals. CCBHCs were developed to bring a new model of comprehensive mental health care to sustain community-based access across our nation. Both models have strong bipartisan support in the state, Congress, and federal administrations. Yet their core funding mechanisms and services will fall under Medicaid changes in H.R. 1. The individuals and families we serve will not go away with these changes, but their access to the care that they need will, unless we take steps to address the impact to our state system. This bill offers a bridge and support to assist with the increase in compensated care that our safety net mental health centers, community health centers, hospitals, and emergency medical services face with H.R. 1 implementation, and will help to manage immediate disruption to all of these systems. This will help support our providers to remain financially viable so that we can keep treatment accessible. By state and federal mandate, as a CCBHC and Community Mental Health Center, we must serve all people regardless of their ability to pay. We know the need in our community is growing, while the means of how they access these services will be shrinking. The people in our communities, they don't have a safety net for treatment. And despite our state and federal mandate, we don't have a safety net to provide this treatment. As a provider and a member of this community, and more importantly, as a mom who has little kids who benefit greatly and are doing well because of their own mental health care, I urge you to support this bill and the foundation of our behavioral health system in Minnesota. And what this translates and looks like, my absolute last meeting yesterday was with the family who came to the clinic and I was on my way out. Their 13-year-old last week had tried to
to attempt suicide. And they were looking for a place to go and were relieved when they called us that morning and were told, hey, come in today and let's have a conversation, let's get care going. I'm never gonna tell this caregiver who makes $11 an hour and has a $6,000, now I forgot the term, but anyway, I'm never gonna tell her to pick us over her rent and over her groceries. But I'm also never gonna say, don't come here. But that's the impact on our families and our communities. And so as a provider, I have to figure out how we're gonna do the best job we can to keep our doors open so that families like this can keep coming. Thank you.
Thank you so much. Ms. Doris, welcome. Introduce yourself and proceed.
Good morning, Madam Chair and members of the committee. My name is Sarah Torres, and I'm the CEO and Head of Operations at Riverland Community Health Center. We are a federally qualified health center in the West 7th neighborhood of St. Paul. I'm here today on behalf of the Minnesota Association of Community Health Centers, MANAC. MANAC represents Minnesota's 17 federally qualified health centers. We provide primary care, dental, behavioral health, and pharmacy services at over 80 locations across the state. We're proud to be part of this unique coalition of providers where we, like our counterparts here, serve all Minnesotans regardless of insurance status or ability to pay. Thank you for the opportunity to speak in support of the Uncompensated Care Fund. Federally qualified health centers of Minnesota are a cornerstone of Minnesota's healthcare safety net. We provide comprehensive medical, dental, behavioral health, and pharmacy services. Last year alone, we provided over 585,000 low-income visits to our patients across urban, rural, and underserved communities. 31% of our patients were uninsured, and 44% rely on Medicaid, underscoring a unique patient mix disproportionate to the population as a whole. We provide quality care in a safe and trusted setting for those who cannot afford or access care otherwise. Primary care is one of the most effective and evidence-based strategies for reducing overall healthcare costs while improving patient outcomes. By providing timely preventive services, chronic disease management, and early intervention in a trusted environment, we're able to help patients avoid costly ED visits and hospitalizations. For safety net populations in particular, primary care serves as the front line of the healthcare delivery system. Health centers have always operated on limited budgets, with many of us reporting just days cash on hand. We're deeply concerned that the anticipated increases in the number of uninsured patients we're already seeing will stretch us beyond our capacity. Under current conditions, we provide roughly $46 million in uncompensated care. This is far beyond our federal 330 grant and state subsidy. Uncompensated care places immediate pressure on clinic operations, staffing, and services. When others close their doors or reduce services, we rise to the occasion. We fill gaps and continue our commitment to serve all who are in need. We seek collaborative partnerships and continue to do more with less, but as I said, this pressure is mounting. The Uncompensated Care Fund would provide additional support to health centers when we need it the most, ensuring every Minnesotan continues to have access to vital medical, dental, and behavioral health care services and life-saving medications. We urge your support to protect Minnesota's healthcare safety net and the patients who depend on it every day. Thank you for your time and consideration.
Thank you so much. Members, comments, questions? Senator Liskey.
Thank you, Madam Chair. Senator Wiklund. I'm just reading through the bill, obviously, with it just being introduced today. Haven't had a lot of time to read it. I'm just trying to understand the funding mechanisms. Are you going to be increasing or reducing the EMS funding to take care of the hospital program side? Or is it just they're increasing across all of them?
Senator Wiklund.
Madam Chair, Senator Liskey, it would be an allocation for each aspect of this bill, so there wouldn't be anything taken away from any existing program or any other part of it. So.
Senator Liskey.
Thank you, Madam Chair. Thank you, Madam Chair. I just wanted to verify because it's just kind of, obviously with the blank spots, it's hard to tell what's going on. Thank you.
Senator Abler.
Well, thanks, and I appreciate the intent of the bill, and I think as it'd be nice to get something actually done in this world, and I don't want to cut human services to find money for anything. And I think the governor is absolutely wrong-headed on the entire approach that he's gotten there. And I think particularly the hospitals are the ones in the most dire straits. And, you know, I'm sympathetic to providers, all these letters, oh, it'd be nice if we can get some money. But I just think realistically that's a long ways off. And I think the resolution of this is going to actually snag itself into the whole documented and undocumented commentary, which I just even heard on the radio this morning, which is going to color the discussion and create much dialogue. And so I know under EMTALA, we have to provide under the 48, if a person could die within 48 hours, then anybody can get that regardless of status. But I just want to help you navigate this torturous thing, and the House can barely agree on committee minutes once in a while, so it's a long path. But I really, particularly the part about, I mean, ambulances, we got to have them, you know, I mean, it's just a world of hurt out there if you know, they can't even be a provider to work at lousy rates to take care of people anymore based upon our infrastructure. But I think that there's something to be said about particularly the hospital part, which is where the crisis of crisis lies. And as I mentioned before, I, for one, am willing to dip into the till and say that this is something that we should agree on, that Minnesotans, I think, would largely agree on, that it's actually worth spending the money and preserving that just most essential infrastructure. And with a nod, sorry, I'm a provider too, like hey, oh, it's payroll again. Oh no, are we going to be okay? It's really hard. But I think that with this and maybe suspending the tax and rebasing and giving some flexibility and demanding that Hennepin County quit running their hospital by a county board and actually have people know what they're doing, run it in conjunction with many of the doctors and nurses there, get a nice restructured board, we can actually go home with something. That's just my encouragement, and thank you for weighing in on this.
Did you have any comments or?
Thank you, Madam Chair. I would just say that, yes, we didn't fill in numbers in here. I think we're still working on how to quantify the hospital needs, how the definition of distressed hospital would fit in here, and then figure out, how many hospitals does that include and what could be meaningful in terms of support, because as Senator Abler mentioned, we are constrained in our resources. I think that I was concerned in the beginning that last year we did do some work to appropriate money for EMS and for FQHCs, but as Mr. Fox mentioned, there still is a great need. If you look at one of the grant programs, the report said that for 1 year, the total losses of eligible grantees was determined to be $40 million, and we allocated $16 million over 2 years for that program. So there's definitely need, well beyond what we've appropriated. Same with the FQHC and community health, community mental health type providers. It's, there's just been more uncompensated care need than what we've put aside in our appropriations last year. So we will keep working on that. Next Tuesday, I will bring bill language forward that will discuss, additional targeted funding. It will acknowledge the special concerns we have about Hennepin County Medical Center, and also will include more language around what sort of accountability or reporting and transparency that we feel should be discussed and brought forward to make any of these proposals work. And so I will try and get that language out ahead of time so people can take a look at it, but we will keep working on that for next week.
Members, other questions? Seeing none, we can go on to the next bill.
Thank you.
Senate File 4672, Senator Wiklund.
Thank you, Madam Chair. Senate File 4672 is a pretty, much more mundane bill. a few months ago, when the report came out from the OLA about the performance audit regarding behavioral health grants, I was talking with staff and asked nonpartisan staff if there would be a way that we could address some of the concerns that were brought forward by maybe looking at statute and just trying to bring more clarity to existing statutes to help mitigate some of the problems. And so what this bill does, it's very, like I say, pretty straightforward and a small attempt to address some of these concerns. It has 4 sections, and they relate to DHS statute and grant program language. So I'll just go through the section 1 is taking out the word substantial in a provision, because what we were hearing, the feedback we were getting was that the word substantial didn't have a definition that DHS felt they could use, so it wasn't clear to them when it applied, and that seems like a problem when we're trying to have actions taken and are providing direction to the agency. Section 2, it updates the adult mental health grant statute, and what we did was remove services that are currently covered by medical assistance and services that have their own grant statute that exists elsewhere. This was done to create more clarity. It seems like if a grant has a statute language elsewhere, we shouldn't have it duplicated in this other section. And then section 3, it is the same process, but for children's mental health grants. And section 4, there was a report that was repealed, but it had a cross-reference in it to some other reporting that we wanted to see continue. And so this just clarifies that the reporting under this program is supposed to continue and make sure that people don't think that the reporting isn't needed anymore. So that's all this bill does. If you have any questions, please let me know. I need to work with the agency, with DHS some more on these items to make sure that there isn't some other unintended consequence by, taking these services out of this particular section. But I will continue to work on that, and I'm open to questions.
Senator's question. Seeing none. Senator Kupek.
Sorry, I do have one. Thank you, Madam Chair. In the bill, in section 3, and then the part that takes out the school-linked mental health services. So what are we doing to school-linked mental health services?
Senator
Madam Chair, Senator Kupek, if Senate Council can address that.
Madam Chair, committee members, so this statute allows DHS to develop grants that relate to these purposes. This is removing school-linked behavioral health grants because they have their own statute now that has appropriations directed to it.
Thank you.
Any other questions? Seeing none, we were going to lay over Senate File 4672. Finally, Senator Utke.
Senator Utke.
Thank you, Madam Chair, and I'm happy that Senator Mann has been waiting all morning for this bill, so welcome. But Madam Chair and members, Before us, I have Senate File 4783. And this bill is in response to the OLA report that came out last month on the EIDBI kickbacks. It is giving the department authority to expedite rulemaking. The department claimed they were unable to take certain actions with regard to kickbacks and credible allegations of fraud in the EIDBI program. A little history: the legislature established the Early Intensive Developmental and Behavioral Intervention, which is the EIDBI benefit, in 2013. The Department of Human Services oversees the administration of the EIDBI benefit. The OLA got involved in this issue in 2024 after receiving a complaint from an individual. In response to the complaint, the OLA reviewed the reasons why DHS's Office of Inspector General closed complaints about EIDBI providers without further investigation. When the OLA inquired about 3 complaints involving kickback allegations, DHS officials asserted the department did not have authority to investigate allegations of kickbacks in the EIDBI program, unless the allegation also included non-kickback conduct that met the definitions of fraud, theft, abuse, or error. Because DHS believed it did not have authority to investigate or sanction the kickback allegations alone, according to DHS, it pursued legislation in the 2019, 2024, and the 2025 legislative sessions to receive such authority. In 2025, the legislature adopted legislation that added explicit authority to sanction MA providers that solicit, receive, pay, or offer to pay kickbacks. Senate File 8783 directs the Commissioner of Human Services to use expedited rulemaking under Minnesota Statute Section 14.389 to amend the rules of the Department of Human Services to clearly include kickbacks in the definition of fraud. With the change, medical assistance payments during investigations of kickback fraud can be suspended. This bill gives DHS the authority they believed they were missing in what we all read in the OLA report. So, Madam Chair, that is the bill before us. I understand there may be a little concern about the rulemaking. Open to having those discussions as we move forward.
Senator Utke, I think it's not so much a concern about rulemaking, but just that there has been alternative proposals put forward to address this particular issue, and so we just want to make sure that we understand what the kind of the best path forward is to make it happen.
Fair enough.
Members, are there any questions or comments about the bill? Well, thank you, Senator Utke, for bringing this forward. I do, it is something that I think we should work to make sure we take care of it and get, so that there is clarity and we don't run into a case where somebody is interpreting something in one way that we aren't intending. So,
right.
Thank
you.
you.
I appreciate it. Being it was brought to us by the OLA, I mean, I think it's appropriate, and whether it's this bill or others, so that we address the issues, so that it gives the agency the authority that they believe they need or the additions they need. So thank you.
Right. Thank you. And so Senate File 4783 is laid over. Thank you, Senator Utke. And with that, we've reached the end of our agenda and we are adjourned.